learning case basically. Because we don't think the diagnosis is ACS not related at all. I think this is the most likely diagnosis happen in this patient. Okay, so our topic today is subcoronary hemorrhage and what SAH lah. So non-traumatic SAH. When we talk SAH, there is a two: is traumatic or non-traumatic lah. Non-traumatic SAH occur in 3% of all stroke, and SAH usually affect younger patient around this age, about 40 or 50 years old. And patient, younger patient more often than other non-stroke. And then there is a risk factors, hypertension, smoking, alcoholism, personal or family history, genetic disease, as drug abuse. So in this patient, you can see that the age is about 40 or 50, like the when this is SAH can occur lah. And then patient ada underlying comorbid hypertension. So it's a risk for aneurysm SAH. Okay. So even though SAH is rare, but it carry high mortality and morbidity. Case fatality approach 50%, and some study shows it's much higher than that lah. And then even though patients survive, half will experience a chronic disability and a chronic significant reduction in health-related quality of life. So it's important not to miss a SAH lah, but it's not as easy as we said lah. Because to diagnose a spontaneous SAH is like find a needle in a haystack lah. Means it's difficult. Why? Because headache account for only 2% of all ED visit, but SAH occur in 1 out of every 100 headache. So it's very rare. We talk about spontaneous SAH, not MVA punya SAH. Okay. So miss and delayed diagnosis is quite common, and I found that in a studies the apa tu percentage of the punya miss of diagnosis about 13.7%. But again, it varies from study to study lah. Okay, so this is a journal that published in American of Emergency Medicine, where data is collected from 2003-2013, and they try to find the prevalence of misdiagnosis for acute SAH. Any diagnosis SAH that delayed more than 24 hours considered from the initial presentation considered a misdiagnosis. So among the studies, they found that 700 or more patients were treated with acute SAH. Then the patient yang miss about 76 patients, which is 13.7% of the total SAH case yang miss. So when we look at the two different studies, Kowalski et al. In 2004 and Dukas et al. 2019, we can see that most of the misdiagnosis is happen in emergency department, about 43%. Because it's not surprising lah, because every acute problem patient will go to ED lah, the most easily accessible place, 24-hour available. So most often diagnostic error occur due to no CT performed. 41 patient out of 56, about 73%. And then preliminary misdiagnosis usually migraine and tension headache. Similar with this case presentation, about 36% of case. Okay. And then we look again at the Dukas et al. 2019, and then the most different false diagnosis initially assessed is headache. Headache about 30 patient. So diagnosed as a headache. Headache means that patient a benign primary headache, cluster headache, migraine, diagnosis. So we can see the trend pattern is almost like our patient. Okay. So there is three reason why we miss the diagnosis of SAH. First is a failure to appreciate a clinical spectrum of ACH. Second, failure to obtain initial non-contrast CT and understand the limitation in the diagnosis. And the third is failure to perform LP, lumbar puncture, and interpret result properly. So the problem, the first issue is failure to appreciate clinical spectrum of ACH. The main issue is the ACH usually presented with diverse clinical presentation. No specific clinical presentation. So, they can presented with any type of macam headache yang biasa, macam migraine boleh datang macam tu And then classical thunderclap headache not commonly present lah.
Thunderclap.
Usually we think that usually SAH they presented with thunderclap headache. Thunderclap headache is defined as a headache that reach minimum intensity within second to minutes lah. But in this patient, the patient complain of headache almost 6 days before visit to ED. And then near 40% of aneurysmal SAH patient are awake, alert, and neurological intact. This make a clinician sometimes didn't do initial CT scan because patient commonly not sick. Usually we misinterpret that if patient SAH, usually they are sick, comatose. Basically, almost 40% patient can presented like our patient, awake, alert, and neurological intact. And then sentinel headache can occur in 15 to 60% of patients. Sentinel headache basically a headache that persistent for few weeks, few days to few weeks, can happen up to few weeks. It may be because of slow leakage of the aneurysm. Thunderclap headache tu macam headache that reach the minimum intensity within second or minutes. Faham tak?
Minimum
reach a maximum intensity within second to minutes.
Sekejap je headache dia.
Usually kalau orang migraine dia akan gradually macam tu. Tapi kalau ni tiba-tiba bangun sakit sangat kuat within minutes, within seconds to minutes. That we call it a thunderclap headache. But the sentinel headache like a headache yang biasa lah. Dia macam pain tapi dia persistent for few weeks and months. The problems with sentinel headache is quite common in SAH, but sometimes we think that it due to a benign primary headache like macam migraine ke apa-apa. So but this is considered a red flag because initially before the SAH burst bleed, they can have these symptoms. When we relate to the our case, we can see that the patient already headache for 6 days, kan? On 4th days baru dia sampai ke apa tu, klinik sejahtera. They give a medication, and the 5th days he go to ED visit, and the 6th day baru second visit, and then after day 9, day 10 of headache, patient come up mati. Okay. So they can have a 3 different distinct presentation. The problem is when they appear well and atypical. That's the issue. Where we can miss. Sick comatose is very easy. Classic presentation is very easy. But when they appear well and atypical presentation, which is quite common in this SAH. Okay. When we talk about what usually they presented, they can presented like any kind of headache, which is when patient datang muda, usually we think is most common diagnosis is a benign primary headache, and because migraine is more common. They can presented with neck stiffness by examination, subjective neck stiffness, lethargy, vomiting. But when we see that neck stiffness and subjective neck stiffness is the important positive likelihood ratio, means that if patient ada headache with neck stiffness, clinically or patient complain neck stiffness, there is a higher probability patient ni might have a SAH compared to other symptoms. Faham tak?
Neck stiffness
about 6.59 likelihood ratio. So neck stiffness is the important physical and clinical symptoms that we must ask during our examination. Okay. So when we compare patient without SAH and patient with SAH, almost similar. Dia punya presentation kan? Kalau yang average dia 44, 55 but not surprisingly patient with SAH datang mainly by ambulance. But when we look at the neck stiffness on history, about 75% patient with SAH presented with headache and neck stiffness, compare only 35% patient headache without SAH. Kan? So bila kita tengok balik, rupanya neck stiffness ni yang paling important lah, history When we talk about thunderclap headache, 60% patient without SAH pun boleh cakap is thunderclap headache, because it's more subjective lah. Subjective Understand Okay. Because of the diversity of the clinical presentation of SAH, so the clinician they create this Ottawa SAH clinical decision rule lah. Okay. So what is the Ottawa clinical decision? Basically, it create a decision rule just to facilitate clinician when we need to do a further investigate. Okay. But the problem with this Ottawa SAH rules is high sensitive, almost 100%, but very poor specificity, about only 50%. Okay kan. So macam in clinical practice is almost useless lah. In academic purpose, yes lah. Kalau nak jawab essay exam kan, this one you can goreng lah. Tak spesifik 50% lah. Okay. But some kena tahu lah, just nice to know lah. There is 5-6 important component. Okay. So the second component is failure to obtain initial non-contrast CT and understand the limitation in the diagnosis. Okay. Because of patient, 40% of patient can present with headache, sometimes they don't do a CT because they think it's headache, like migraine common migraine Okay. So non-contrast CT is considered as important diagnostic tool, but the sensitivity of CT scan decrease when onset of headache to CT delay. Because the blood progressively dilated by normal flow of CSF. So we can see that the first CT scan done for this patient is almost 4-5 days after the onset of headache. So there is a possibility that the sensitivity of the CT is reducing, lead to misdiagnosis of this patient. Okay. Patient with anemia, SB less than 10 with low hematocrit also can lead to a false negative CT brain. Why? Because in patient in anemia, usually especially if the bleeding is very minimal, if the bleed can appear like isodance from the CT. And then the third, CT film review by non-expert. Sometimes the bleeding very subtle, that we can SAH bukan macam bleeding ada very thin macam tu. So when we talk about sensitivity of plain CT, the highest of sensitivity of plain CT is less than 6 hours of onset. It's almost 100%. But when it's progressed, usually the sensitivity is reduced. 6 hours to 24 hours, about 92%, and day 5 about 58%. Usually the sensitivity is decreased at day 4 and forward. Not surprisingly, in this case, we can get a normal CT because it's already almost day 5, which is we can miss almost half of the bleed. Okay, it's just various studies from meta-analysis regarding the sensitivity of the CT scan less than 6 hours. Okay, the third is failure to perform LP and interpret result properly. Okay, so lumbar puncture is mandatory if there is strong suspicion of SAH despite normal CT, although it's controversial. Prospective studies of patients with acute severe headache, the diagnosis of SAH was missed by CT in 14% with SAH who had initially CT performed more than 6 hours after the onset of headache. So ada study tu, they noted that almost 14% of patient with SAH presented more than 6 hours, CT brain normal. Tapi they noted that from the lumbar puncture ada pula. Okay. So when we talk about guideline, memang in 2012 guideline for the management of aneurysm subacute hemorrhage by AHA, class 1 level of evidence B. Bagus juga kan. If CT brain is non-diagnosis, should be followed by lumbar puncture. Okay, but it's controversial if LP might be unnecessary if CT scan negative of blood is performed within 6 hours onset, because we know that if CT brain is less than 6 hours performed during the onset, you know that the sensitivity is very high. So no need to give a patient more risk of LP. CT scan review by expert and no anemia. Okay, what exactly are you looking for on LP? So we look in two components. One is red blood cell and then xanthochromia. Okay, red blood cell. Red blood cell tahu kita, result might be uncertain if traumatic tap present. Kita tengok darah dekat CSF, tapi about 10 to 30% of LP is a traumatic tap. They can have it macam blood macam tu. How to differentiate between traumatic tap and SAH? Usually in traumatic tap, the RBC amount is decreasing in trend from tube 1 to tube 4. You know it's a traumatic tap. Tapi kalau SAH, usually the RBC is not decreasing in trend. Okay. And then presence of xanthochromia, but the problem with xanthochromia is developed 12 hours after SAH, can persist up to 2 weeks. Okay. So if we do LP early, we don't expect that the patient ada xanthochromia. Okay. So this is the difference between 4 sample So in A tu is a normal clear CSF from tube 1 to tube 3. In B is a lumbar puncture in a patient with traumatic tap, where we can see that from eyeballing kita nampak dia punya blood tu memang pekat dia sama daripada tube 1 sampai tube 3. And tube C tu we can see it's not clear, it's like yellowish color. That's a xanthochromia. Okay. The D is we can see that the concentration of blood tu nampak macam decreasing trend. Daripada satu pekat, second tu kurang pekat, tiga tu clear. So usually it's a traumatic tap. Okay. Tapi isu regarding traumatic tap ni, how we define a traumatic tap? We know that kita ambil multiple tubes, kita tengok tube 1, tube 2, tube 3, tube 4. The amount of RBC decreasing. Tapi what is the cut off of RBC amount that consider this is traumatic tap, this is SAH. So they did this is a Gosinski. Dia buat lebih kurang 500 sampel 500 sampel. They found in a 299 patient ada blood in dia punya lumbar puncture. But from this 299, 11% ada SAH. 288 lagi adalah just traumatic tap. But bila dia tengok, basically kalau tube 4 tu amount dia less than 500, usually blood cell tu tak ada in patient with SAH. So they can consider if a tube 4, if the amount of RBC less than 500, we can say that this is a traumatic tap. Tapi kalau more than that, usually kita tak boleh cakap. Okay. So this is summary summarize hemorrhage CSF finding. Usually kita tengok opening pressure, appearance RBC. Okay. What is xanthochromia? It's a yellowish tinge to the CSF. It's called xanthochromia, caused by red blood cell degeneration in the CSF, as we see in a SAH. Usually macam kuning-kuning. Nampak apa kan? Dia macam kuning-kuning lah. Saya kencing ni tu. Okay. So how we can do better in this patient? So it's very difficult question to ask. Should I perform LP routinely if SH the only concern? Because in a guideline they said that LP, if CT is non-diagnostic, you need to proceed the LP. But you must understand the risk and benefit of LP itself. The risk of LP such as epidural hematoma, LP, post LP headache, infection and all. So it has a risk. And then it's quite not common lah kita buat LP dekat ED. Jarang lah, tak pernah tengok. Just purposely to diagnose the SCH. And then what is the benefit? Because the prevalence of SCH tu sangat rare. 2% of headache, among these 2%, 1 of 100% yang ada SCH. Is it worth to do a LP? Okay, not routine. Kalau LP tu tak bagus, harmful, should I just order the CT angiogram? For CT angiogram, usually is sensitive to detect aneurysm, but it does not tell you if the aneurysm is bleed or not. Sometimes when we see there is aneurysm, basically aneurysm tak boleh, kita akan overtreat and they put the patient surgically. And that is it cost effective at all lah? Dengan ni a lot of patient answer. So there is many algorithm yang orang try to buat lah. Untuk try to minimize the risk of misdiagnosis or delayed diagnosis of SCH. So at the end, if the head CT tu normal, negative more than 6 hours, there's still a shared decision making. Shared decision making ni maksudnya kena discuss lah. tak ada concrete decision lah. Sama dia nak buat ni ke buat ni. Okay. So ada apa-apa thought lah? Bos?